what is the one take-home point you'd like this audience to if they forgot the rest of your talk? And maybe we'll start with Steve, since you're impression. We'll just go down that one.
Yeah. My point would be, I think that severe pancreatitis needs to be regionalized. And if you're not in that regional center, you should get those patients that you know are sick to a regional center. And if you are that regional center, you need to have a team that I'm lucky enough to have of surgeons, gastroenterologists, interventional radiologists, etc., to take care of this disease. But I just see way too many patients who spend too much time out in smaller hospitals who are well-intended, who are not providing state-of-the-art care.
Andrew?
So I would, it's kind of hard because it's a big topic, but I think that it was emphasized again in that last talk, the importance of cross-sectional imaging in this population. I mean, we use ultrasound a lot. It often is listed as the first modality of choice in various different guidelines for various different reasons. And I think the point was well emphasized there at the end. If that ultrasound is negative and you need to look at that pancreas, you should not hesitate to go to cross-sectional imaging.
I would say always remember the patient's symptoms, especially as it relates to CF or pancreatic disease, and not rely only on a single test. I often see people just using a fecal elastase and making a lot of decisions just based on that. So remember your patient's symptoms.
Okay.
Basically, kids aren't small adults, and I think all of us know that, but at the same time, we just can't expect everything that works in adults to work in children too. So when we use adult data and try to extrapolate it to children, we just have to take it with a grain of salt and really start looking into pediatric specific data and how endoscope and endotherapy can be adapted to kids.
Questions?
I enjoyed all your talks, Steve. I enjoy your kind of pragmatic intellectualism. I guess 2 points. If I had a patient with idiopathic pancreatitis, I would not send them for a cholecystectomy unless they had an EUS that showed sludge. If it did not show sludge or stones, I would not prefer them for cholecystectomy. At least in our experience, those people, if they don't have gallbladder sludge, they don't get another biliary attack. That'd be one point. The other point would be, even at our academic center, UAB, which I might say at some points is pseudo-academic, where did this attention to the serum amylase, where can I find a reference from 1950 or 40 where if it's elevated, you don't do a cholecystectomy? At our place, the surgeons still discuss, well, the patient's amylase, check it every day, if it's still a little bit elevated, we're going to wait to do the cholecystectomy. I would love to find that reference. Even these patients were sitting on the floor. So please help me so I can educate my surgical colleagues.
That's wonderful. Let me just to your first comment. So it's hard for me to argue with you about the EUS. It really is. Other than that, you just put another test between me and that gallbladder. And financially, I can probably take the gallbladder out for about as much money as that EUS costs. So 5 gallbladders, 5 EUSs, fine. What I would say though is that if you start talking about doing an EUS in that idiopathic pancreatitis before I take the gallbladder out, I would disagree with that, because the ERCP honestly is more dangerous than cholecystectomy. So as a diagnostic test before you start doing ERCP, and Adam Sluk and I have talked about that in detail when I was back here in Pittsburgh, but it's here or there. I feel your pain with the amylase. My own trauma surgeons trend it. They just make decisions on it. I have no understanding where they reference that from. It has no role in my decision making other than it makes the diagnosis down definition.
I need to find the reference. It's got to be somewhere. You surgeons love these little things and you hold on for decades.
Yeah, the one thing I would tell you that do is in, and I love what you're talking about, like you talked about that early patient-driven reinitiation of feeds. I mean, it makes a huge amount of sense to me, but you have this clinical dilemma that a subset of folks actually have a return of their pain. And so then when you re-challenge them, and so we've kind of looked at what the amylase has been like in those patients and maybe said, we'll wait to feed them again until the amylase is down. But other than that, trending amylase makes no sense to me. I agree.
Just a question also. So like for patients with idiopathic pancreatitis over like 40 years of age in our center allowed us, we do an EUS just to make sure there's no underlying malignancy, even though cross-sectional imaging is negative. Would you, like, what's the time for your
I don't blame you. I mean, honestly, but that's your hammer, right? And so that's how you're hitting the pancreas. My hammer is taking that gallbladder out. So we don't know the right answer there.
Oh, no, I know. But I guess like timing wise, do you have a timing for your cystectomy? Do you
Same admission.
Same admission.
Yes.
Okay,
If
so
I
do you know what
could,
to do with it?
if I could. But it's neither here nor there. Now, the other thing, just that brings it up, and I didn't bring it up in the talk, though. Listen, the epidemiology of alcohol-induced pancreatitis is poorly understood as well. I mean, the reality is that there are a number of people in their 50s and 60s who have gallstones and admit to drinking in the ED who get alcoholic pancreatitis slapped on their chart when in fact they have biliary pancreatitis. I mean, and they don't get their gallbladder out in the face of stones. Now, let's really talk about those folks. So I think a very careful alcohol history is important in understanding some of the work that's been done, that the exposure to alcohol to truly cause that disease is now thought to be extensive, like at least 35 drinks a week. So if you're hearing like a glass of wine or two a night and some 55-year-old woman who's truthful to you, please don't label her with alcoholic pancreatitis. That's just another thing I've seen happen. Please be careful about that.
We have a question over there.
Dr. Hughes, I think you're a practical surgeon and a wonderful observer. And if you could pioneer your observations and carry on with your practice, I think you can make a national change. I think we're going way overboard in the gastroenterology era, where our advanced fellows are looking for drilling a hole through the retina and reaching the rectum. And we're cavalier in endoscopy nowadays. I'm a program director in advanced endoscopy, and what I see is the knife at war in gastroenterology. I think surgeons are very well trained and very skilled at doing wonderful things, and I totally agree with you that from a cost-effective perspective, the surgeon should intervene. In a necrosectomy case at the time where you presented, and I think you should make your point, nationwide, and train, surgeons at academic institutions, because they're refractory at intervening. I have a hard time convincing my surgeons to do a J-tube, to do a laparoscopic cholecystectomy, and to do a necrosectomy, a surgical laparoscopic necrosectomy, because the patient is too sick. And we end up, doing necrosectomy after necrosectomy after necrosectomy over months. Whereas, this intervention should have been one-time stop shop. And to your point, from a cost effectiveness perspective, are you looking at idiopathic pancreatitis because you could not find a reason at the index time, one-time acute pancreatitis episode? Are you looking at the patients who present with recurrent acute pancreatitis and you're not finding a reason? And to your point, cholecystectomy is not that expensive, but it is expensive to bring the patients recurrently to your office for visits, and you're doing HIDA scans, with the intention of finding.
Well, there's a lot there.
And you're doing ultrasound, and you're doing endoscopic ultrasound, and you're still labeling that idiopathic pancreatitis. Yet, microlithiasis, you can't prove it. You're not going to do analysis of bile. I think that's more cost ineffective than just taking the gallbladder out, making sure the patient doesn't have, let's say, complete venism, or some ductal anomaly with an MRCP, and then proceed with a cholecystectomy. And then if afterwards, post-cholecystectomy, you're still faced with recurrent acute pancreatitis, maybe genetic, testing or other things, should come into playing a role.
Like I said, there's a ton there, lots to talk about.
And for you,
Let's say, so practical, right? I said some of what I was going to say would be a little controversial. Am I taking, am I down in the ED seeing every pancreatitis, and as soon as their ultrasound's negative, saying they should take their gallbladder out anyway? I'm not. I mean, I honestly don't have time. But if somebody has had at least 2 episodes of acute pancreatitis and is labeled idiopathic, Chris Forsmark or Peter Dragonoff or Dennis Yang will come down and say, what should we do? We've got good cross-sectional imaging. There's not a neoplasm there. Do you want an EUS in this setting? So honestly, my point, principle, good partners between GI and surgery, I think, are really critical to this disease. And and are sadly lacking, probably because of my colleagues more than the gastroenterologists. There are not a lot of surgeons who are enthusiastic about this disease because typically it takes up a lot of time. I'm very lucky in that the surgical intensivists report up to me as the chief of general surgery, so it is largely a surgical intensivist disease until I do a nice operation, and then a week later they're better and they go home. I don't know if I have time to talk about the other things. I think your points are intriguing. They're very intriguing.
Why don't we move on? Marcin, you had a question?
Yeah, thank you all for a very nice session. I just to send the fellows in the audience with the right message, I would kindly disagree with my friend, Dr. Steve Hughes, about the first attack, pancreatitis. I would say at this day and age, we don't have evidence to remove gallbladders for non-gallstone pancreatitis. There's 70% of those patients, and not just in our registry and other registries with first attack, that will not have another attack again. And they do not have gallstones. So hopefully you work them up and you looked at that. So it's hard to make that recommendation because if we take that and the cost of the cholecystectomy and whatnot for a first attack and an index, it would be hard to push that agenda, Steve, yet. Acute, thank you for agreeing. Acute recurrent though, we struggle with those. We see families and the EUS is negative, the MRCP is negative, CT, ultrasound, they don't have gallstones, and the mom or the dad were better because they had a cholecystectomy for acute recurrent pancreatitis. They're pushing the cholecystectomy for a child. Now I know where to send them. But even with high-dose scans, they don't have biliary dyskinesia, so it's hard for the surgeons. They want an indication-driven surgery. So maybe we can start deriving some of that literature, but it's an easier argument to make.
I completely agree. Listen, I would never recommend it for a 7-year-old. I mean, that makes no sense to me, even if they're morbidly obese. I think that the distribution of the etiologies in your patient population compared to my 55-year-old obese woman who happens to have a poor quality of ultrasound that's been read as negative, it is a very different way to kind of consider what should come. And as I kind of fessed up to, I think this is most typically for me in the setting of recurrent acute pancreatitis or in the setting of somebody who's been labeled with alcoholic pancreatitis who actually has gallstones, who presents later in life than where you're typically going to see alcoholic pancreatitis unless somebody took to the bottle in their 50s. You know, I've seen 65-year-old men who came in and said, I had a glass of wine, they told me I had alcoholic pancreatitis. They got gallstones, and people aren't taking a gallbladder out, you know, so.
I'm going to ask a question for Andrew. What are we doing to standardize atrophy, that description that we see and the variability that exists? And then my second question is, what about fat? And have you seen it increasing? Is there a detection bias in that, or is there just more fat being seen, or MRIs and soft tissue contrast just getting better? And what are we doing to quantify that so we're talking the same language?
So the atrophy question, as I mentioned, is getting more quantitative. There have been linear thickness measurements available by ultrasound, and we recently published on CT for quite some time. Those, as I mentioned, are problematic in my opinion. In the criteria that were put together by the CPDPC and some of these other groups that are trying to now, that have done some of the agreement studies and also trying to do imaging studies going forward, there are some criteria that have been defined for thickness, still thickness though, for the adult pancreas, in terms of where they're dropping patients into various categories of atrophy. Again, that adults are not, or kids are not little adults, and so those thickness measurements are problematic for kids. So there are groups, there are some of us that are trying to now get to this more volumetric assessment. And there was over at the NIH session that's going on in parallel to this, there were some talks about the application of artificial intelligence to now do image segmentation. Because it is manually labor intensive to segment out the pancreas to get a volume. I truly do though think that is going to be the way to go. And that to me reflects the different lies of the pancreas in the abdomen. Some patients have a bigger onset and a smaller tail, you know, some patients have a thin neck and a fat body, and, you know, et cetera, et cetera, et cetera. Right? So there's all this normal variation that if you start using thickness measurements, it's difficult to account for. Whereas volumetric measurements, we may find that, you know, you need a certain mass of cells to have the needed function. And so I think the volumetric approach is now with augmented with artificial intelligence in terms of image image segmentation to get us there are going to be the way to go. Now, do we have cutoffs for what's normal? There actually is a autopsy study out there that that pulled out pancreases and measured volumes back in the day. And so I have some of those literature. The literature do exist. But not only do you need to find normal, but you're going to need to find the diagnostic cutoffs for various different diseases. So long answer to your question, but for volume or for parenchymal atrophy, I think it's going to be volumetric that we're going. With regard to fat, so I didn't talk about fat, but yeah, so we are seeing more fat in the pancreas. Zach talked about it in the context of cystic fibrosis. That's been long understood. Though not all cystic fibrosis patients get fat. Some just atrophy, et cetera. Otherwise, we are seeing fatty pancreas or pancreatic steatosis, quote unquote, in the context of obesity. And we are, by MRI, now able to very accurately measure the fat fraction. Any of you who have any practice that goes beyond the pancreas and into liver space in NAFLD, right? We use what's called the proton density fat fraction. That's an accepted MR measure, can be achieved in a single breath hold, and it allows you to measure how much of that MR signal is made up by fat. And it gives you a very accurate quantification of how much fat there is in the organ. And so that's where we're moving for that. I think we are seeing it more because our imaging modalities are more sensitive. I think we're also seeing more because of the obesity trends that are coming forward, and we are getting more and more accurate. Now, what does it mean? That still remains to be seen. It does have implications on exocrine function, it has implications on endocrine function. It has potential implications, pro-inflammatory effects on pancreatitis. And so I think this is a field that is growing rapidly right now, as now we're able to see it all of a sudden and quantify it.
Great. And Manav?
So, which is the best imaging modality to look for the disrupted duct? Or, I mean, how do you know if there's a particular sensitivity or specificity for MR to detect that?
So MR of all your imaging non-invasive imaging modalities, ERCP obviously is going to be better than any non-invasive one, but MR is going to be a modality of choice when you want to look at any duct-based finding, whether that's divisum, incomplete divisum, as was mentioned over there, the disconnected duct findings of chronic pancreatitis. So that's going to be MRI. In terms of optimizing detection of the disconnected duct, and even how you define a disconnected duct, what size gap is too big of a gap. Some of them will heal over, right?
Then like disrupted versus truly disconnected.
Correct, right? Because you can have a episode that will disrupt the duct. You'll have a gaping hole in the duct, but that can heal over or fibrose over. And so we're still a little bit shaky on the diagnostic criteria, but MR is going to be your test of choice for assessing duct-based processes, regardless of what they are.
Quinn, and this may reveal my ignorance, are there pediatric therapeutic endoscopy fellowship programs in the country?
So there's not, there are therapeutic, there's one therapeutic pediatric endoscopy program in San Antonio, Texas, headed by Dr. Sandeep Patel, correct? And so he has a dedicated pediatric training program. Otherwise, for pediatric gastroenterologists. Otherwise, it would be training either as junior faculty or with a traditional adult program.
Is there a need to have a more standard fellowship?
So yes, there's probably definitely a need. There's interest, and then it's one of those things where, of course, you wouldn't want to train too many people. Of course, there's a numbers issue, just like an adult. But there's definitely regions and centers that do have needs that right now have adult colleagues to help with their procedures, but it is less than ideal.
Okay. I think you have a comment in the back.
Yes, if I may, if you stole the question from me. Our program, Sandeep and I are partners, but our program is not by any means a standardized program, being so unique and original. We have trained a Stanford fellow that returned to Stanford, Travis Easter.
Right, he's at Children's LA.
Yes,
he's in Los Angeles. Right.
But he was trained GI at Stanford. So here's how he's trained. He is not a fellow, a pediatric fellow is not training on pediatric patients. So most of the patients that a pediatric fellow is trained to return to attend to pediatric population are adults.
Correct.
So I think, in a consortium, if you wish, maybe this is the time, to meet them and form, a discussion group.
Well, we've been talking for quite a while,
Yes.
and the issue with that is if you train just on pediatric patients, then you're talking about the length of the training period, right? My program, I was training an adult program. I trained pediatric. We just finished training another pediatric fellow. They mostly train on adult patients because it's mainly, it may take 2, 3, 4 years to train only on pediatric patients. And also from the standpoint of just technical difficulty, mainly from biliary standpoint, maybe not as much as pancreatic, there's more technically difficult biliary cases in adults that might be useful in the training program for whether it's adult endoscopists or pediatric endoscopists.
I think from an ethical standpoint, in my mind, is the pediatric fellow has no ways of following from a clinical standpoint a post-ERCP complication. So that falls either onto the remaining trainees, in the program, the adult trainees who have to cover for the patient, or it falls onto the actual attending who may or may not be present for follow-up. So I think those are important dilemmas, whether they're medical legal aspects of care or patient care, or they're frustrating on the colleagues, trainee colleagues, because I witnessed those. I think those also should be taken into consideration because this is a pediatric fellow attending to adult procedures and cases, yet having to provide post-procedural care and not being able to do so. And about the pediatric EUS, I trained, and I can tell you, I think you should come up with an atlas of age-related endoscopic findings on pancreases. And if you could do like a multi-center, I think it's fascinating because there's an evolving change in the pancreas anatomy and overall morphology as the kids age.
I
And
totally
I think
agree.
that would be a
it's-
wonderful thing for the pediatric gastroenterologists, to see.
Okay.
Because the kids have this chronic pancreatitis like normal pancreas.
In the interest of time, let's do one more question and then we'll end up things up.
Oh, I actually have a question in regards to one of your comments that you just made in regards to that ethical dilemma. So common Cincinnati programs. And so in regards to that scenario, I think you were referring to a pediatric gastroenterologist training in the ERCP, and then that particular trainee not being able to handle the complications when they're under the training aspect of things, correct? Right. Well, I think that goes across the board, regardless of whether a pediatric or an adult trainee. The trainee is not going to handle the complications that might occur when they're in the process of getting trained. Still would belong to the mentor who actually would handle those complications. So I think it's irrespective of whether it's a pediatric trainee or whether it's an adult trainee. I'm not so sure if there's definitive dilemmas in regards to the aspect that you were mentioning.
Okay. Well, why don't you guys take that off the line then, because in the interest of time, I just want to thank you, the panelists again, the speakers, for a wonderful discussion, taking a very, what supposedly is a 101 and stirring controversy and raising more questions than answers. So thank you for that.